Hello, good morning students. I hope you all know about me. I'm Kamna Pradhan, your new teacher, and today I'll be teaching you Unit 7 of Medical Surgical Nursing, and the name of the chapter is Nursing Management of Disorders of Male, Adult including Elderly, Reproductive System. Okay, so first what do we see in this is we have to see about the anatomy and the physiologic view. Okay, so in male there are several organs. I hope you can see. In the male, several organs serve as a part of the both urinary tract and the reproductive system. Okay, and disorders in the male reproductive organs may interfere with the function of one or both of the systems. So the structures in the male reproductive system include the external male genitalia, consisting of the testis, epididymis, scrotum, and penis. And the internal male genitalia consists of the vas deferens, also known as the ductus deferens, ejaculatory duct, and prostatic and membranous section of the urethra, seminal vesicle, and certain accessory glands such as the prostate gland and Cooper gland. Okay, so this was the anatomic view. Now we will move on to the physiologic overview. So the testes have the dual function, that is spermatogenesis. That spermatogenesis means production of the sperm, and secretion of the male sex hormone, that is testosterone, which includes and preserves the male sex characteristics. Okay, so the testes and ovoid sex glands are encased in the scrotum, which keeps them at a slightly lower temperature than the rest of the body to facilitate spermatogenesis. Okay, then we'll leave all this because it's not so important. Then the penis is the organ for both copulation and urination. It consists of the gland penis and both the body and the root. Okay, so this was the overview of the anatomical and the physiological male reproductive system. Okay, so I hope you can see the image. This is the male reproductive system, and this is the urinary bladder, this is the ampulla, this is the seminal vesicle, ejaculatory duct, this is the prostate gland, this is the bulbourethral gland, this is the anus, and the perineum. This area, this is given here. Okay, and this is the symphysis pubis, this is vas deferens, corpus cavernosum, penis, urethra, glans penis, porpus, and urethral meatus. This is the testis and the scrotum. So next we move on to the assessment and physical examination. Okay, so nursing assessment, we'll see history and physical assessment. Okay, it begins with the evaluation of the urinary function and symptoms. Okay, whenever the patient comes to you, so what we do is we have to evaluate the urinary and the function and the symptoms. Next we move on, and it includes a focus on sexual function as well as manifestation of sexual dysfunction. Okay, then next is the patient is asked about his usual state of health and any recent change in general physical and sexual activity. So when the patient comes, when we take the issue, we have to ask about his usual health, like whether he has the health problems from before, or whether he has any recent changes, recent surgery, or recent like some illness that he's undergoing. Okay, we have to ask him everything about this. And next we move on, that is any symptoms or change in the function are explored fully. So if he says that he has any symptoms or any change, then we should fully explore it. Okay, we should ask him fully that what medications he are taking, or whether he is having any other symptoms related to it. Okay, so next is the patient is also assessed for dysuria, hematuria, and hematospermia. So when we see this dysuria is difficulty in passing the urine. Hematuria means blood in urine, and hematospermia is blood in the ejaculation. When the patient ejaculates, whether he has some bloody kind of discharge or not, we should assess that. Okay. So next is assessment of sexual function, and this function is an essential part. So as we are talking about the reproductive system, we should always ask him about the sexual function and whether there are any dysfunctions in it. Okay. We must also assess about the chronic illness. If the patient has this diabetes, hypertension, or cardiac disease, this will directly or indirectly affect the sexual health. Okay. So we must also assess about the use of medications that affects the sexual function. So whether he is on any drugs, that we have to see the side effects of the drugs, and whether that drug is having any side effect in the sexual function or not, we should see that. Okay. The next, we must also collect history regarding stress and alcohol and smoking. So see, stress, alcohol and smoking, these are the three that will affect the sexual health very often. Okay. And so we must also ask about the past health history and major illness, hospitalization, surgery, and infections related to reproductive system, and illness that affect reproductive function and are mumps and rubella. So like I told earlier, when we take this history collection, whenever we have to ask about the past health, like whether he had any major illness, whether he was hospitalized, or whether he had surgery in the reproductive system, like whether he had any infections that cause this reproductive function to deteriorate are mumps and rubella. Okay. So next we will see the physical assessment. Okay, in addition to the usual aspect of physical examination, two essential components address disorders of the male genital and reproductive system: the DRE and the testicular examination. DRE is the digital rectal examination. Okay, the DRE is used to screen for prostate cancer and is recommended annually for every man older than 50 years. Okay, so when the male they reach the age of 50 years, then they are always recommended to undergo the DRE. Okay, so the DRE enables the skilled examiner using a lubricant gloved hands placed in the rectum to assess the size, symmetry, shape, and consistency of the posterior surface of the prostate gland. So what they do in DRE is that the skilled person, like the doctor or any technicians, okay, they just put this gloved hand, they put the lubricant, and they will put the fingers into the rectum, and they will assess this posterior, means the posterior side of the prostate gland. Okay, what do they see for? Is they see for the size, symmetry, shape, and consistency. See, this is the way they do the DRE. Okay, so they have put the glove and they have put the lubricant, and they are assessing the posterior part of the prostate gland. Okay, so the clinician assesses for tenderness of the prostate gland and palpation for the presence and consistency of any nodules. The DRE may be performed with the patient leaning over the examination table on positioning the man in side-lying position with legs flexed towards the abdomen, or supine with legs resting to stirrups. Okay, so we can put the patient in the side lateral position, side lying position, and we can tell the patient to put their hands, like legs up towards the chest, and sit there comfortably. So to minimize discomfort and relax the anal sphincter during the rectal examination, the patient is instructed to take deep breath and exhale slowly as the practitioner inserts the finger. So this procedure is done in many of this type of instructions is given in many of the examinations. Okay, so this is one of it. So where we tell the patient to take deep breaths. Okay, so when we take deep breath, and when the patient practitioner just puts his finger inside the rectum, then we have to tell him to exhale slowly. So if possible, he should turn his feet inward and so his toes are touching. Although the examination may be uncomfortable and embarrassing, it is the most important screening tool. Okay, so next we move on to the testicular examination. The male genitalia is inspected for abnormalities and palpated for masses. So what we do is like the testicles, no, they are like palpated for masses or any other abnormal lump-like structure. Okay, the scrotum is palpated carefully for nodules, mass, and inflammation. Examination of the scrotum can reveal such disorders as hydrocele, inguinal hernia, testicular torsion, orchitis, epididymitis, and a tumor of the testis. Okay, the penis is inspected and palpated for ulcerations, nodules, inflammation, discharge, and curvature. If the patient is uncircumcised, the foreskin should be retracted for visualization of glans penis. The testicular examination provides an excellent opportunity to instruct the patient on how to perform a testicular self-examination and the importance in early detection of testicular cancer. TSE should begin during adolescence. Okay, so what we do is like we have to palpate the whole male genitals. Okay, first we see the scrotum. In scrotum we have to see for the masses or inflammation and nodules. Then after that we move on to the penis. In the penis we should see, palpate and see for the ulcerations, nodules, or any discharge, and we should see for the curvature of the penis. Okay, then later on, if the penis is circumcised, then the glans penis is automatically seen. But if the patient is uncircumcised, then we have to retract the foreskin, then we can see the glans penis, and we have to inspect the glans penis properly. Okay, so after that, whenever we are doing this testicular examination, we should instruct the patient to do this testicular self-examination. Like self-examination is whenever he is at home, he doesn't need to come to the hospital every time for the examination. Okay, so next we move on to the diagnostic evaluation. So this was the physical assessment. Next week is the diagnostic evaluation. Okay, there is a wide range of diagnostic study may be performed in men with reproductive disorders. Okay, the nurse should educate the patient about the purpose, what to expect, and any possible side effects related to this test and examination prior to the testing. So we as a nurse should always educate the patient. Okay, should always educate the patient about the purpose, why we are doing it, what can he expect from the procedure, and what are the possible side effects related to the test or examination before the procedure. The nurse should not note trends in results because they provide information about disease progression as well as the patient's response to therapy. So here are some of the diagnostic evaluations, that is the prostate specific antigen test, ultrasonography, prostate fluid or tissue analysis, test of male sexual function. Okay, so what is prostate specific antigen test? The cell within the prostate gland produce a protein that can be measured in the blood called the prostate specific antigen, PSA. It is a sensitive but specific test for prostate cancer. In the absence of prostate cancer, serum PSA level may vary with age, race, and prostate volume. So increased level may indicate prostate cancer. However, a number of other conditions such as BPH, acute urinary retention, and acute prostatitis may cause high PSA level. Values of PSA may also increase after ejaculation. PSA levels are measured in nanograms per milliliter, and in most laboratories, value less than 4 nanograms per milliliter are generally considered normal. Okay, so what is PSA? PSA is like we can see this. These are these proteins that are produced by the prostate gland. Okay, and that can be measured in blood. Okay, so these are the PSA level. These are like, it is increased in some of the levels like BPH, acute urinary retention, acute prostatitis, and even after the ejaculations. Okay, so it is not always the prostate cancer that causes the PSA level to rise. Okay, so if the PSA level is not risen due to the prostate cancer, then BPH and other causes will be the cause for the PSA level rise. Okay, so the value of PSA level will be done in nanograms per milliliter, and if and the normal value considered is 4 nanogram per milliliter. Okay, so next is the ultrasonography. Transrectal ultrasound (TRUS) may be performed in patients with abnormalities detected by DRE and those with elevated PSA level. So if the PSA level are increased, then we will go to the transrectal ultrasonography. Okay, then after DRE has been completed, a lubricated condom covered rectal probe transducer is inserted into the rectum. Water may be introduced into the condom to help transmit sound waves to the prostate. TRUS may be used in detecting non-palpable prostate cancers and in staging localized prostate cancer. Needle biopsies of the prostate cancers are completely guided by TRUS. So, transrectal ultrasound, what do we do is, this is done after the DRE, that is digital rectal examination, is performed in the patient, and this can also be done when the PSA level is elevated. Okay, so after the DRE is completed, then we put this probe, probe inside the probe that is covered with condom inside the rectum, and then we also put the water inside the condom to allow the transmit of the sound waves. Okay, then after this, we can what can we do with TRUS is it may be used in detecting non-palpable prostate cancer and in staging localized prostate cancer. Okay, needle biopsy. So whenever a needle biopsies are done, it has to be done only with the TRUS. Next, we move on to the prostate fluid or tissue analysis. So specimen of prostate fluid or tissue may be obtained from culture if disease or inflammation of the prostate gland is inspected. Okay, so a biopsy of the prostate gland may be necessary to obtain tissue from histological examination. This may be performed at the times of prostatectomy or by means of perineal or transrectal needle biopsy. 6 to 12 biopsies from 4 prostate zones may be obtained during the TRUS guided biopsy. So, what is said is that prostate fluid specimen may be obtained only if there is inflammation of the prostate gland or disease in the prostate gland is inspected. So, a biopsy is taken for the histological examination. So, this may be performed at the time of prostatectomy or by means of perineal or transrectal needle biopsy. Okay, so test of male sexual functions. If the patient cannot engage in sexual intercourse to satisfaction, a detailed history is obtained. Nocturnal nocturnal erections occur in healthy males of all ages. Nocturnal penile luminescence test may be conducted in sleep laboratories to monitor changes in penile circumference during sleep using various methods to determine number, duration, rigidity, and circumference of penile erection. The results helps to identify whether the erectile dysfunction is caused by physiological or psychological factors. Okay, so this test of male sexual function is done to see whether there are any erectile dysfunctions or any dysfunction in the sexual activities of the males. Okay, so what we do is like in this we can see the patients are taken to the laboratory and a sleep laboratory test is done in the patient. Okay, and whenever it is done, then we have to see during sleep what are the changes that are monitored during sleep. That is, in penile circumference during sleep, usually various methods to determine number, duration, rigidity, and circumference of penile erections. Okay, so when we do this, then this helps to identify whether there is erectile dysfunction, that is physiologic or psychologic factors. Okay, so next we move on to the disorders of the male reproductive system. So there are basically 5 disorders. As disorders of the penis, disorders of the prostate gland, disorders of the testes, disorders of scrotum, and disorders of urethra. So under disorders of penis, we have paraphimosis and phimosis, priapism, cancer of penis. Then next is disorder of prostate gland, that is benign prostate hypertrophy, benign or also known as benign prostatic hyperplasia. Next is prostatitis, prostate cancer. Then disorder of testes, we have cryptorchidism, epididymitis, orchitis, testicular torsion, testicular cancer. The next is disorder of scrotum, that contains hydrocele, varicocele, and disorders of urethra, that is urethral stricture, urethritis, hypospadiasis, and epispadiasis. Okay, so from all this, today we will be starting with the disorders of prostate gland, that is benign prostate hypertrophy or hyperplasia. Okay, so what is benign prostatic hyperplasia? Benign prostatic hyperplasia is a non-cancerous enlargement or hypertrophy of the prostate and is one of the most common diseases in aging men. It can cause bothersome lower urinary tract symptoms that affect quality of the life by interfering with normal daily activities and sleep patterns. BHP typically occurs in male older than 40 years. So, benign prostatic hyperplasia is something that the prostate glands will be enlarged, and it is not due to the cancerous cells, it is due to the non-cancerous cells. Okay, the prostate just gets enlarged, and it is most commonly seen in the aging men. So this is the normal prostate and this is the enlarged prostate. Okay, this is the bladder, this is the urine, this is the normal prostate, normal urethra. Okay, but in this case this is the bladder, this is the enlarged prostate, and the urethra is compressed. So here you can see the same thing. This is the prostate that is enlarged. So this is what we call benign hyperplasia of prostate. So next we move on to the etiology. Okay, so etiology, the precise molecular etiology of it is uncertain. So the reason till now is precise reason till now is unknown. So what are the other etiologies are the age, genetics, sex, steroids, hormone, physical activities, and obesity. Okay, so from the name itself we can see age means when the BPH will rise markedly with age. So as the patient's pH age is above 50 years, 60 years, then we can see the BPH. Second one is the genetics. If there is any familial history, okay, then it can have the cause of the BPH. Third one is the sex steroid hormone, testosterone, dihydrotestosterone, and estrogen. There are increased risk of BPH with increased serum concentration of DTH and its metabolites. Okay. Third one is the physical activities. Decreased physical activity. Some of the patient will have this sedentary lifestyle. Okay, if they don't do any physical activities or they don't have any regular physical exercise. Okay, so they are at the increased risk of BPH. Last one is the obesity. The obese patients have the greater chances of having BPH. Now, next we move on to the pathophysiology. The cause of BPH is not well understood, but testicular androgens have been implicated. Okay, so this all is, I have just shortened it a bit so you can just see this. Okay, so any of the etiology, that is the whatever we studied before, that will cause the increase of the estrogen level. Okay, so then these prostatic cells become more responsive to estrogen. If there is increased level of estrogen in the body, that means the prostatic cells, it becomes more responsive to estrogen. Okay, so that will lead to increased proliferation of the prostatic cells, that will lead to benign prostatic hyperplasia. Because in the male patients, in the males, or in any healthy human, okay, males, okay, the estrogen levels are lower than the testosterone. Okay, so as you know, estrogen can be seen in the females and the testosterone will be more in males. Okay, so when it increases, then the prostatic cells will become more responsive to estrogen. So when this will become more responsive, then there is proliferation of the prostatic cells. Okay, so that will cause the benign prostate hyperplasia. Okay, then when there is a benign prostate hyperplasia, then a gradual dilatation of the ureter, that is ureter and kidney hydronephrosis can occur. Urinary retention may result in UTI because urine that remain in the urinary tract serve as a medium for infective organs. Okay, then clinical manifestations. Okay, BPH may not lead to lower urinary tract symptoms. If symptoms occur, they may range from mild to severe. Severity of the symptoms increases with age, and half of men with BPH report having moderate to severe symptoms. Okay, so obstructive and irritative symptoms may include urinary frequency, urgency, nocturia, hesitancy in starting urine, decreased and intermittent force of stream, and sensation of incomplete bladder emptying, abdominal straining with urination, decrease in volume and force of the urinary stream, and dribbling, that is urine dribbles out after urination, and complication of acute urinary retention and recurrent UTIs. So when there is obstructive and irritative symptoms, that will include urinary frequency, that is the urinary frequency may increase, like they will feel like they are having this more urinary frequency. Okay, and that is urgency, like whenever they get urine, that it will be very urgent, like they have to go to the bathroom whenever they get they won't be able to hold the urine for a while. So nocturia, then hesitancy in starting urination, that is if the patient whenever they will go to the washroom and they will try to urinate, they will have this hesitancy, like the urine will not pass at once, like they will have this hesitancy in starting the urination. Okay, so a decreased and intermittent force of the stream, the urination stream, it will be not way of the normal, it will be very decreased kind, like they will have only a little amount of urine passing through it. Okay, and the sensation of incomplete bladder emptying, so whenever they pass, after they finish passing the urine, also they will feel that they have not passed the entire urine, they will feel the retention of the urine in the bladder. Okay, then abdominal straining with urination, so whenever they try to forcefully urinate, they will have this abdominal straining, and the decrease in the volume and force of the urinary stream that I've told earlier, and dribbling means after they pass urine, then after some time there will be dribbling of the urine. Okay, like after passing of the urine, also after some time they will dribble the urine out. Okay, and then the complication of acute urinary retention and recurrent UTIs. So in a healthy person, the normal residual urine amounts to not more than 50 milliliter of the middle-aged adults and less than 50 to 100 ml in the older adult. Okay, ultimately the chronic urinary retention and large residual volume can lead to azotemia. So when there is a chronic urinary retention, like there is large residual volume of the urine, then it can lead to azotemia. Okay, azotemia means accumulation of nitrogenous waste and kidney failure. So generalized symptoms may be noted, including fatigue, anorexia, nausea, vomiting, and pelvic discomfort. Other disorders that produce similar symptoms include urethral stricture, prostate cancer, neurogenic bladder, and urinary bladder stones. Okay, so next we move on to the assessment. So the health history focuses mainly on the urinary tract, previous surgical procedure, general health issues, family history of the prostate disease, and fitness of the possible surgery. So whenever we get a patient, then we should always have the health history of the patient. Okay, so in this condition we must always focus on the urinary tract, previous surgical procedures, general health issues, if there is any family history of the prostate disease, and if the patient is fit for possible surgery or not. Okay, a patient voiding diary is used to record voiding frequency and urine volume. So a DRE, that is digital rectal examination, often reveals a large rubbery and non-tender prostate gland. A urine analysis is screened for hematuria and UTI is recommended. A PSA level is obtained if the patient is without a terminal disease for whom knowledge of the patient presence of prostatic cancer would change management. So we have to do a DRE, we have to do urine analysis, and a PSA level is done if the patient is without terminal disease and for whom knowledge of the presence of prostate cancer would change management. So if there is any prostate cancer, then we have to change the management. Okay, so next is the American Urological Association AUA symptom index, or International Prostate Symptoms Score, IPSS, can be used to assess the severity of the symptoms. So next we move on. Other diagnostic tests that will include recording urinary flow rates and measurement of the post-voidal urine residual urine. If invasive therapy is considered, urodynamic studies, urethrocytoscopy, and ultrasound may be performed. Complete blood studies can be performed, and cardiac status, respiratory functions are assessed because a high percentage of patients with BPH have cardiac or respiratory disorders due to their age. Okay, so next is, I hope you understood about the assessment. Then next is the medical management. Okay, the medical management, the goals of the medical management of BPH are to improve quality of the life, improve urine flow, relieve obstruction, prevent disease progression, and minimize complications. And the treatment depends on the severity of the symptoms, the cause of the disease, the severity of the obstruction, and the patient's condition. If a patient is admitted on the emergency basis because he is unable to void, he is immediately catheterized. Okay, on the emergency patient, if the patient comes to emergency with all this, he is unable to void urine, so we have to catheterize him immediately. The ordinary catheter may be too soft and pliable to advance through the urethra into the bladder. So in such case, a thin wire stylet is introduced by a urologist into the catheter to prevent the catheter from collapsing when it encounters resistance. Okay, so this is done by the urologist. So what they do is they insert the stylet into the normal catheter, and then they introduce the catheter into the urethra. Okay, so a metal catheter with a pronounced prostatic curve may be used if if use is obstruction is severe. So if a cystotomy, that is incision into the bladder, may be needed if to provide urinary drainage. So next is the watchful waiting. Okay, this is the term you can see in BPH, that is, it is the approach to a medical problem in which time is allowed to pass before medical intervention or therapy is used. During this time, repeated testing may be performed. So watchful waiting is something that before we do, it is done mostly in this mild cases or intermediate cases. Okay, so where we can just, before we approach to the medical like we approach to the surgical procedure or any of the medical management, we will just watch and we will just wait and watch for the therapy. Okay, so what do? Is like we just watch, we just see, and we just perform tests and wait. So next we move on to the pharmacological therapy. BPH includes the use of alpha-adrenergic blockers and 5-alpha reductase inhibitors. Okay, so what does the alpha-adrenergic blockers do? This includes the effuzosin, that is uroxetrol, or terazosin, that is Hytrin, etc. It relaxes the smooth muscles of the bladder, neck and prostate. This improves urine flow and relieves symptoms of the BPH. Okay, what does it do? It basically relaxes the smooth muscles of the bladder, neck and prostate. Okay, and it will that will help in the urine flow, and it will also relieve the symptoms of BPH. The second one is 5-alpha reductase inhibitor. This includes finasterides, okay, that is Proscar, etc., and are used to prevent the conversion of testosterone to DHT and decrease prostate size. So what does it do is like this testosterone, if it gets converted to DHT, that is dihydrotestosterone, that will cause BPH. So it will just prevent the conversion of testosterone to DHT and will decrease the prostate size. Okay, so next is the surgical treatment. So surgical treatment. There are other treatment options include minimal invasive procedure and resection of the prostate gland. So several forms of minimal invasive therapy may be used to treat BPH. Okay, first one is transurethral microwave therapy, that is TUMT, involves the application of the heat to prostatic tissues. Okay, so a transurethral probe is inserted into the urethra and microwaves are directed to the prostate tissue. The targeted tissue becomes necrotic and swells. Okay, so what is done is this transurethral probe, we will insert it into the urethra, and then microwaves are directed to the prostatic tissue. This will help the targeted tissue become necrotic. So to minimize damage to the urethra and decrease the discomfort from procedure, some systems have water cooling apparatus. Okay, so other minimal invasive treatment option include transurethral needle ablation, that is TUNA, by radio frequency energy, and urolium stent. TUNA uses low level radio frequencies delivered by a thin needle placed in the prostate gland to produce localized heat that destroys prostate tissue while sparing other tissues. The body then reabsorbs the dead tissue. Okay, so what is done in TUNA is like low level radio frequency delivered by thin needles are placed in the prostate gland. Okay, in prostate gland we will just keep this low level radio frequency delivering thin needles, then localized heat is produced, and this localized heat that will destroy this prostate tissue while sparing other tissues. So the dead tissues are then absorbed by the body. Prostatic stents are associated with significant complications, example incrustations, infection, chronic pain. Therefore, they are used only when patients with urinary retention and patients who are poor surgical risk. Okay, so next one is the surgical resection. Surgical resection of prostate gland is another option for patients with moderate to severe lower urinary tract symptoms of BPH and those with acute urinary retention or other complications. So when a surgical resection used is that when the patients are with moderate to severe lower urinary tract infection symptoms of BPH and when there is acute urinary infections and other complications, then we use the surgical resection. Okay, the specific surgical approach, open or endoscopic, and the energy source, electrocautery or laser, are based on the surgeon's experience, the size of the prostate gland, the presence of the other medical disorder, and patient's preference. If surgery is to be performed, all clotting defects must be corrected and medications for anticoagulation withheld because bleeding is a complication of prostate surgery. Okay, so this all must be kept in mind. Okay, so transurethral resection of prostate TURP remains the benchmark for the surgical treatment of BPH. So this is the most commonly and the most effective surgical procedure. Okay, it involves the surgical removal of the inner portion of the prostate through endoscope inserted through the urethra. No external skin incision is made. It can be performed with ultrasound guidance. So what they do is they, through an endoscope, they will just peel off the inner portion of the prostate and none of the outer external skin incision is made. Okay, the treated tissue either vaporizes or become necrotic and sloughs. The procedure is performed in the outpatient setting and usually results in less post-operative bleeding than a traditional surgical prostatectomy. Okay, so other surgical option for BPH includes transurethral incision of prostate TUIP, transurethral electrovaporization, laser therapy, and often prostatectomy. Okay, TUIP, this is transurethral incision of prostate, is an outpatient procedure used to treat smaller prostate. One or two cuts are made in the prostate and prostate capsules to reduce constriction of the urethra and decrease resistance to flow of urine out of the bladder, and no tissues is removed. Open prostatectomy includes the surgical removal of the inner portion of the prostate via a suprapubic, retropubic, or perineal approach for a large prostate glands. So prostatectomy may also be performed laparoscopically or by robotic assisted laparoscopy. So we can see that TURP is the most commonly used surgical treatment of the BPH, and the surgical options can be TUIP, that is transurethral incision of the prostate, and if there are larger prostates, then we have to go for prostatectomy. So this was the medical surgical management. Now next we move on to the nursing management. Okay, so potential, what are the nursing management? So nursing management. Okay, so first nursing management, in nursing management we have to assess the patient. Nurse assess how the underlying disorder has affected the patient's lifestyles. Questions to ask during assessment include the following: has the patient's activity level or activity tolerance changed? What is the presenting urinary problem? Has he experienced decreased force of urinary flow, decreased ability to initiate, voiding, urgency, frequency, nocturia, dysuria, urinary retention, or hematuria? Does the patient report back pain, flank pain, and lower abdominal or suprapubic discomfort? Possible causes of such discomfort include infection, retention, and renal colic. Has the patient experienced erectile dysfunction or changes in the frequency or enjoyment of sexual activity? The nurse obtains further information about the patient's family history of cancer and heart or kidney disease, including hypertension. Has he lost weight? Does he appear pale? Can he raise himself out of bed and return to bed without assistance? Can he perform usual activities of daily living? A comprehensive functional assessment may determine how soon the patient will be able to return to the normal activities after prostatectomy or any of the other surgical procedure. So we have to diagnose the preoperative, postoperative and potential complications. Okay, so next we move on to the preoperative interventions. What can we do is like we can reduce anxiety. Okay, when the patient usually admitted to the hospital or surgical center on the morning of the surgery, because contact with the patient may be limited before surgery, the nurse must establish communication with the patient to assess his understanding of the diagnosis and planned surgical procedure. The nurses clarifies the nature of the surgery and expected post-operative outcomes. In addition, the nurse familiarizes the patient with pre- and post-operative routines and initial measures to reduce anxiety. Because the patient may be sensitive and embarrassed discussing problems related to genitalia and sexuality, the nurse provides privacy and establishes a trusting and professional relationship. Guilt feeling often surfaces if the patient falsely assumes a cause and effect relationship between sexual practice and his current problems. He is encouraged to verbalize his feelings and concerns. So how do we reduce anxiety is by communicating to the person about his disease, what we are going to do about the disease, what we are going to do in the procedure. We must educate him properly, and if the patient is feeling awkward discussing his feelings, okay, so it is our responsibility to just go and teach him about the procedure and other things. Okay, so next is we must relieve discomfort. If the patient experiences discomfort before surgery, bed rest is prescribed, analgesic agents are administered, and measures are initiated to relieve anxiety. If he is hospitalized, the nurse monitors his voiding pattern, watches his bladder distension, and assists with catheterization if indicated. Okay, so for relieving discomfort, we will use certain measures like if the bed rest is prescribed, then we must allot a bed for the patients, then we must give this analgesic agents, and also we must take initiative to relieve the anxiety. Okay, we must also monitor his voiding patterns, and we must see for the bladder distension, and if catheterization is needed, we must assess that. Okay, an indwelling catheter is inserted if the patient has continuing urinary retention or if close monitor is needed because of the laboratory test results in indicate azotemia. Okay, the catheter can help decompress the bladder gradually over several days, especially if the patient is an older adult and hypertensive, and diminished kidney function or urinary retention that have existed for many weeks. So next is providing education. So what should we do is before surgery, we must review the patient the anatomy of the affected structure and their function in relation to the urinary and reproductive system using diagrams and other educational aids if indicated. The education often takes place during the pre-admission testing visit or the urologist office. Okay, the nurse explains what it takes while the patient is prepared for diagnostic test and then for surgery. The nurse also reinforces information given by the surgeon about the types of incision, which varies with surgical approach, and describes the likely type of urinary drainage system and the recovery room's procedure. The amount of information given is based on the patient's need and question. Nurse explains procedure expected to occur during the immediate preoperative period. Answer questions to the patient, family, or significant other may have to provide emotional support. In addition, the nurse provides the patient with information about postoperative management. Okay, so this is basically like the health education that we give in the clinical side. Okay, we must educate the patient fully about the procedure, what are the side effects, what are the procedure, what incisions is to be made, what is the surgical procedure, everything we should educate the patient. Okay, the last one is the preparing the patient. If the patient is scheduled for prostatectomy, the preoperative preparation must be done. Okay, anti-embolism stockings are applied before surgery and are particularly important to prevent PGE if the patient is placed in lithotomy position during surgery. An enema is usually administered at home or in the evening before surgery or in the morning of the surgery to prevent post-operative straining which can induce bleeding. Okay, so the next one we have is post-operative nursing intervention. So the post-operative is maintaining fluid balance, relieving pain, monitoring and managing potential complications, then promoting home and community-based care. Okay, so under this we can see maintaining fluid balance. Okay, so during the post-operative period, the patient is at a risk of imbalanced fluid volume because of the irrigation of the surgical site during and after surgery. Okay, so during the surgery there is a lot of fluid irrigation is done, so it can lead to the fluid imbalance. Okay, the urine output and the amount of the fluid used in the urine must be closely monitored to determine whether irrigation fluid is being retained and to ensure or adequate urine output. An intake and output record including the amount of fluid must be used for irrigation must be maintained. The patient also monitored for electronic imbalance, example electrolyte imbalance, example hyponatremia, increasing blood pressure, confusion and respiratory distress. Okay, so after this post-operative we must maintain fluid balance to avoid certain medical emergencies or certain complications. Okay, so relieving pain, as the patient will be having pain, so we must always have this we must always help the patient to relieve the pain. Okay, like we have to assist to sit and dangle his leg over the side of the bed on the day of the surgery. Okay, the next morning is assisted to ambulate. If pain is present, the cause and location are determined and severity of the pain and discomfort is assessed. The pain may be related to incision and may result in excoriation of the skin at the catheter site. It may be in the flank area, indicated a kidney problem, or it may be used by bladder spasms. Okay, so if the patient experiences bladder spasm, then the medications that relax the smooth muscles can help ease the spasm. Example that we can use are Urispaz or Diatropan. Okay, then next we move on to the monitoring and managing potential complications. So what are the potential complications? We will see that is the hemorrhage, venous thromboembolism, that is VTE. Next we have the potential catheter problems, urinary incontinence and sexual dysfunctions. Okay, so this will be given in your notes, so you can study from there. And next is promoting home and community-based care, so educating patients about self-care. Okay, the length of the hospital. So I hope you have understood this subject, this chapter. So today we have done the assessment of the male reproductive system, this anatomic and physiologic overview, assessment. Then we have seen the physical assessment, diagnostic evaluation. Then we have moved on to the disorders of the prostate, and prostate benign prostatic hyperplasia is done. So if you have any doubts or any questions regarding it, you can ask me. Okay, so if you have any, so these notes will be provided to you, and I hope you all enjoyed the class. And if you have any problem, you can freely ask me. Okay, thank you.